Hello, I'm Sandra Hurst, and thank you for allowing me to present to you my MSN Practicum project on the need for increased staff awareness of acute inpatient stroke. Introduction. There is a need to increase staff awareness of stroke recognition of inpatients. This project includes information of this need in its literature. The objectives are to discuss project's purpose, discuss plans for implementation, disseminate literature and video to fellow staff on stroke awareness, review impact on nursing, and discuss project's findings and evaluation. The purpose of this project is to increase awareness of inpatient stroke recognition to nursing staff and provide literature and video as support of this need to improve stroke competency. Impact on nursing. Various barriers of stroke care competence impact nursing are associated with unawareness of evidence-based stroke treatments, clinicians' incompetence to practice evidence-based guidelines. And without a stroke care algorithm and nurse training, this could negatively impact nursing care. And now the literature review. Cerebrovascular accident is a common burden condition of inpatients during hospital stays. Delays in recognition and assessment of inpatient strokes reviewed in previous literature studies have shown poor outcomes. The objectives of a quality improvement initiative was to evaluate an in-hospital cold stroke algorithm and staff educational program for decreasing response times for inpatient strokes. Increasing staff awareness of stroke urgency, diagnosis, and treatment is very crucial in vulnerable specialties such as cardiology, nephrology, and cardiothoracic units. However, to a lesser extent, this also includes other specialties. Initiatives on these objectives are being currently addressed, such as specifically overview of inpatient hospital stroke, 2016 National Stroke Guidelines with multidisciplinary team education on specific units. The third and probably the most important literature in this project is to recognize patients' report of a headache, of a severe headache. Headache-associated ischemic stroke was related to stroke misdiagnosis in some studies. In a retrospective study, headache-associated ischemic stroke was misdiagnosed 3 times the cases of other misdiagnoses. Whereas another study has shown that a headache-associated ischemic stroke was present in 55% of subjects with a possible stroke misdiagnosis. A continuous chronic, moderate to severe intense headache implies severe disability related to headache-associated ischemic stroke and the need for evidence-based timely treatment and management. Reasons for delayed response of addressing acute stroke symptoms remain poorly understood. However, some studies have attempted to generate results of these barriers and are associated with inappropriate healthcare facilities for stroke care, health professionals' uncompromised attitude for change, unawareness of evidence-based stroke treatments, clinicians' incompetence to practice evidence-based stroke treatment guidelines, limited staff availability for clinical judgment, and work culture could be contributors to delayed response times. Current studies have reviewed remarkable improvement outcomes derived from interventions such as inpatient stroke code algorithms and rapid implementation of stroke warnings by nursing staff. However, the issues of overlooking symptoms of inpatient strokes continue to be misunderstood. Further studies are necessary to address these issues within various healthcare organizations. Acute ischemic stroke management is time sensitive. Successful stroke management depends on a well-established interdisciplinary team. As the future advances, an increased number of stroke competent facilities would improve the chances of successful outcomes. Despite a positive future on stroke management, barriers of public awareness and professional competence remain an issue. This last literature stated during an analysis associated with the level of nurses' competence, results have shown in larger hospitals, nurses were unaware of appropriate interventions between the onset of acute ischemic stroke and administering tissue plasma antigen, and the indication for administering labetalol and controlling blood pressure in patients with acute ischemic stroke before TPA treatment and dose. These results offer concerns with appropriate nursing staff training and a lack of organization structure that would improve patient and staff outcomes. The implementation will only go as far as disseminating presented literature in a stroke symptom simulation video, followed by an evaluation of staff and fellow students and feedback, without presenting an education or a live simulation at this time. And this was the stroke simulation video that was presented to the staff. Evaluation/findings. One colleague's feedback of project literature stated being surprised and intrigued of learning staff's decreased awareness of inpatient stroke symptoms. Other staff feedback of video stated that they had not had a chance to watch it. The barrier for sufficient feedback was the logistics of the busy, dynamic work environment. However, because the project's components were sent by emails, feedback may be received in various times beyond project's completion. Reflection and future goals. Beyond this project's completion, the goal is to continue to follow up colleagues' feedback with an intent to form a plan to implement a unit educational conference with a feedback form provided, with plans to submit this feedback to the appropriate department responsible for including stroke competency as part of yearly employees' job competency record. This project had increased my own understanding of the importance of stroke competency that increased interest in becoming stroke and cardiovascular certified in the future. A very special thanks goes to my fellow students' feedback and support of this project. This will end the presentation, and thank you for watching.